Our next speaker is Dr. Thomas Wright, and he is going to talk a lot about different modalities for measuring lipedema.
Yes. Yeah, well, good morning, everyone, and wow, this is a great crowd. This is exciting. The crowds get bigger and bigger, so it's exciting time about lipedema. So I'm gonna get started with my slides here. Yeah, I think I missed my disclosure slide. Let me go back. Yes. So my talk today, some of my talk today is going to include some research that I've done, and it was supported by Tactile Medical. So first thing is about compression and intermittent compression pumps in lipedema. So I mean, this is a burning question. So many ladies out there with lipedema don't. There's such controversy among them whether compression is effective, and so these studies needed to be done to prove the value of compression in lipedema. So a TAN just 2 years ago published that compression leads to significantly decreased limb size, and intermittent compression also decreased limb size. And then he also found that exercise plus complete decongestive therapy and IPC all led to decreased pain, improved social functioning, fatigue, and overall general health, measured with the SF-36. And a recent study that's been submitted for publication, but is not quite published, that I showed that it also decreased limb size, extracellular water, and so this is my this is my data here, and we can see here that compression in dark blue here. Let me see if I get this. Yeah, it's in the dark blue. Compression alone decreased the limb size, and then adding the intermittent compression pump further decreased the limb size in all the areas measured. But interestingly, the hip measurements actually increased slightly. This is a TAN's work, and it shows that on the volume on the y-axis that there's decrease in limb volume size by exercise, pumps, and reps. And also he showed decreased pain on the visual analog scale. Just a quick word about bioimpedance. It's where you have these minute electrical currents. They pass through the body, and they, depending on their frequency, they either go intracellular or extracellular, and then we measured the impedance in segments, so through running the current through all four limbs. And so the high frequency goes through all the tissues, and the low frequency just stays extracellular. And so looking at that in these ladies with lipedema, that the compression and the compression plus the intermittent compression pump led to decreases in the extracellular total body water, which really is a ratio, which really this is a measurement of their extracellular water or interstitial fluid. And so this sort of adds a little information to when we're seeing the limb size decrease with compression, it is reducing the extracellular water. Now I want to talk a little bit about the surgical treatment of lipedema. And there's the three most common types of surgery are the Lipedema Reduction Surgery, skin reduction, and manual extraction of lipedema nodules, kind of in that order. So when to consider surgery for lipedema? Well, after the conservative measures. So they're wearing compression garments, they are following a diet, and they've had MLD maybe and sometimes if needed intermittent compression pumps. So who's a good candidate? So BMI of 50, that's very, so obviously, you know, lipedema causes increased BMI, and about 80% of ladies with lipedema, as Karen mentioned earlier, are by the BMI rating considered obese. And now, but once you get to BMI of 50 or higher, you're starting to see some secondary lymphedema just from their BMI. So so that's when I start thinking about emphasizing weight loss before surgery. But it's not really fair for a lipedema ladies to be just by the BMI. And so I also look at the waist to hip ratio, then, you know, we really do want these patients to be diet compliant. So we spend a lot of time discussing low refined carb diet or low carb diet. And really we need them to be at least either have weight loss or weight neutral, because the last thing we want to do is remove this adipose tissue and have it redistribute and come back and be redistributed otherwise, other places. And they really do need to be compliant with compression, because if we're going to proceed with this, and you know, the results of the surgery are highly dependent on compression compliance and overall good to fair health. So multiple studies have shown that lipedema reduction or liposuction can reduce pain, reduce the need for compression in MLD, can even halt or the progression or reduce the stage, and also improve gait and stance. So just a quick word about liposuction. Of course, it's the most common cosmetic procedure. It is a cosmetic surgery focused on just the optimal removal of fat for the maximal aesthetic effect. And then lipedema reduction surgery is a derivative of liposuction in that it uses a liposuction cannula, but I'm going to go into a little more detail how it's not the same. So lipedema reduction surgery is focused on pain relief and functional improvement, much larger volumes. I mean, average is 5 liters of aspirate, and as high as 12 liters of aspirates are removed in a single surgery. It's performed on larger patients. The average BMI of my patients is 42. Larger areas are treated. Longer procedure times. You know, 4 hours is probably an average time, and that's quite different from a cosmetic liposuction, which is, you know, generally an hour or two. And then there's measures needed to be to protect lymphatics should be used. And then also the fibrous tissue and the extracellular glycosaminoglycans are also targeted. We really are going for a complete removal of as much of that diseased tissue in the subcutaneous space. So here are the codes. They're the 15877 through 9. And this is what the commercial insurance policies use for the coverage of lipedema reduction surgery. But these are simply placeholders. They're just the only thing you can, if you look them up, you'll say they're cosmetic lipectomy. That's what it says. There's no official description. There's no assigned value for these codes. And so what that means is when the carriers, because there's no assigned value. There's huge variability on reimbursement. So the carriers can pay whatever they want, and they will pay less than $200 for this surgery. And so, you know, their policies using the 15877 through 9, you know, do not describe or include the risk or skill or time involved. So just a quick word about these patient-reported outcome measures, the RAND SF-36 and the PROMIS. So we've used these, I've used these in following the results of my surgeries. And so here is on this left, here is the, in red is the pre-op values through these domains of physical functioning through fatigue and energy and overall health. And then after surgery, here their ranges are, they average about a 15 to 20 point increase. And you can see that the normal population means that are, you know, they start below and they improve to at least the population means or even, or in some cases a little better. This is just the same data, you know, and just in a graph form showing that, and higher up is better. So you know, over each of these domains, there's improvements in function, and this is comparable to what the improvements seen using the same measure for like spine surgery or other surgeries for chronic conditions. Now this is so we also followed the PROMIS reported outcome, and these are the mobility measures are highlighted here, and you know post-operatively there's a 15% improvement in walking speed, ability to get up and down stairs, increase ability to get up from the floor, and increased ability to stand for an hour. Before surgery, the average mobility score was 51, and it improved to 62, which is an average increase of 10 points. And so in the literature, in studying many disease sports, a 2 to 3 point change is considered clinically important. And so to compare this to, say, a total knee replacement, the improvement in mobility in the literature is reported as 3 point improvement or 5 point improvement. And so we're you know, at least double that improvement in overall mobility for these patients. Now, I'm going to talk a little bit about leg mechanics and how our treatment can affect leg mechanics. So this is just a knee flexion. You know, and a normal knee flexion is 140 degrees, and you need these are the knee flexion degrees that you need to do different activities. So going up and down stairs, you know, you need at least 90 to 100 degrees, sitting down 90 to 110, getting squatting or picking something up, or getting out of a tub, you need 130 to 140 degrees of range of motion. So this is just a diagram or slide I made to show how when the adiposity, the bulk increase, limits the range of motion in lipedema ladies. And so we also, in addition to range of motion, we also measure the angulation at the knee, and so this is showing a valgus angulation at the knee. So what I found is that there's an average of 8 degrees improvement in the knee range of motion postoperatively. There's a 8-degree improvement in the valgus rotation, and an average decrease in the Q angle. And the Q angle is associated with knee pain, and these range of motions that I just explained are very important in mobility. And then all this leads to an 84% improvement in gait. So lipedema reduction surgery, more on the protections to the lymphatics, because we really do, as Dr. Samaro beautifully pointed out, that the lymphatics are always a concern, and may even have a role in the development of lipedema. We need to take extra care to not damage lymphatic function. And so the protections we use are, so we map the venous structures prior to surgery. We use small blunt cannulas and a longitudinal technique, and then it's a very multiple positions. So for optimal orientation, the cannula stroke. So you really have to, they go a full 360 in doing these surgeries to make sure that we're not going to transect any of the lymphatic structures. So this is a slide from a case report that published this year on liposuction can cause lymphedema. So these are this lady had lipedema, and she underwent liposuction with tumescent liposuction with power assistant, and she developed right leg swelling, and right foot swelling, and that's just a close-up of her foot. And you can see that if you can, I hope you can see that she had a positive stemmers and a little fibrosis in the top of her foot. And then this is the lymphocinogram 1 year performed 1 year after, and it as you can see here on the right side, there's lack of uptake and flow through the lymphatic system at 30, and all through 90 minutes, there's lack of flow through the lymph system on that right leg. Thank you very much for your attention.